Thank you. So welcome everyone to our second MGH Senior Health Town Hall. We are so happy you could join us today. I am Susan Edgman-Levitan and will be your moderator for the call today. And I'm the director of the MGH Stoeckel Center for Primary Care Innovation. Before we get started, I'd like to go over a few housekeeping rules. Everyone on the call will be muted to eliminate background noise so that we can hear our speakers. You can view the speaker on your full screen like you're seeing me now, or you can go to the gallery view in the upper right-hand corner if you want to see all of the participants. If your picture becomes jumpy or starts getting out of sync, go to the bottom left-hand corner and click Stop Video, and that should speed up your connection and fix the problem. For questions during the presentations, please use the chat feature in the bottom ribbon below the screen. And we also want to remind you to please do not share or ask questions about personal medical issues, because that information will be able to be seen by everyone on the call. If you do have an important medical question, please reach out to your doctor directly. We are very grateful for the excellent questions you sent us. And if we don't have time to answer all of them on the call today, we'll be sending out more information. We have expert speakers today, but as infectious disease doctors, they are very busy providing clinical care and probably won't be able to stay on the call after their presentations. Dr. Russell will pose many of your questions to them after they finish their formal presentation, so hopefully we'll have time to cover everything that they are experts in that you sent in to us before the town hall today. I'm going to introduce everyone now, so let's get started. And in order, we will hear from Dr. Raj Gandhi, who is, who is the director of our HIV Clinical Services and Education in our Infectious Diseases Division. Dr. Sarah Turbert, who is the Assistant Director of our Microbiology Laboratory in the Infectious Disease Division. And then we'll be hearing from Dr. Matt Russell, who is the Medical Director for Senior Health. And we'll also be hearing from Haley Shanker and Andrea Kirkle, who are nurse practitioners in the senior health practice. And then finally, we'll hear from Dr. Sharon Levine, who is the chief of our geriatric division at Mass General. And so with that, I think we're ready to get started with Dr. Gandhi.
Thank you very much. It's a pleasure to be here today. I appreciate the invitation. I will say, unfortunately, because of other commitments related to clinical care, I will have to leave before the end of the call, but I'm happy to be here as long as I can. So what I'm going to start with is just a little bit about where we are with treatment. This is the area that I'm most focused on. I'm leading a task force at Mass General that's focusing on treatment of COVID-19. And the way I like to think about treatment is it kind of falls into two dimensions. The first relates to the severity of the disease, because the treatment has to be kind of matched with the severity of the disease. And here, the first point I want to make is that for mild disease, which is the vast majority of COVID-19, by far the vast majority, people with mild disease will recover on their own with no specific treatment. Now, when I say no specific treatment, there are plenty of supportive treatments that we give. It's an important thing to say that supportive care does not mean no care. So things like medicines for fever, medicines for discomfort, staying well hydrated. So with supportive care, mild disease in almost all instances will resolve on its own. And in most instances, people with mild disease will and should stay at home where it's the safest place to be. One other point, though, to say about mild disease is people should be monitored carefully, because we have seen here, as well as in other countries, some examples where people start with mild disease and then develop worsening disease, but that's not common. The signs to watch out for worsening disease beyond things like fever and cough, or things like shortness of breath, that's something that you would want to talk to your physician about if you have mild disease, but then just aren't getting better or have shortness of breath. The other dimension of severity of disease has to do with moderate or severe disease, and those are people we monitor in the hospital. And what would warrant hospitalization is really, worsening of symptoms or shortness of breath, and that would be a discussion to have with your physician. So the second dimension that we're focusing on is treatment itself, and what type of treatments would work against COVID-19. And here there's two main categories of treatments that are being assessed. One are antivirals, things that beat down the virus itself. An example of that for other viral illnesses is something called, for influenza, we know there's a drug called Tamiflu. Tamiflu is an antiviral. And so people are working hard to try to develop antivirals for COVID-19. The antiviral that I would say that most people have heard of is a drug called hydroxychloroquine. It's almost always in the news. This is a drug for which in animal studies and in test tube studies, there was some early promise, but we know in medicine that many things that work in test tubes and in animals just don't work in humans. And so there are now clinical trials to try to assess whether hydroxychloroquine does work. I'm part of several guidelines panels that have synthesized all the human data for hydroxychloroquine. And so far, it's really very unclear as to whether it works and if the risks are worth the benefits, or the benefits are worth the risks, I should say. So I think that's something where I would say more to come. These guideline documents I've never been on guidelines that change so quickly, and I anticipate within the next weeks or a month we'll know more about hydroxychloroquine. So far, the data is very mixed. There are other antivirals, actually from the world that I came in. HIV drugs are being repurposed to try to see if they work against COVID-19. So far, the data for HIV drugs doesn't seem to be all that promising, and therefore I tell my patients not to think of that as a treatment outside of a clinical study. The second kind of category of treatments that are being investigated are treatments that really work against the immune system or with the immune system is probably a better way to do it. We know that early on in COVID-19, some of the symptoms are related to the virus, but that later on, some of the symptoms are related to an overexuberant immune response. And so there's a lot of interest and research now into try to, get that immune modulation, get it kind of centered just right so that it's not too little. We need to clear the virus, but that it's not overexuberant or causing damage itself. Where we are with treatment now, in a sentence, is there is no proven treatments for COVID-19 beyond supportive care, which again is not the same as no care. And therefore, what the push is right now is to do clinical trials so that we can understand what does and doesn't work. Most of those trials are focused on people hospitalized. There are some trials launching later this month for people who are have mild enough symptoms that they would be at home, and those are not yet here, but should be here soon. So that's kind of in very broad strokes, a little bit about treatment. I'm happy to pause for a minute and see if there's questions from Dr. Russell, if he wants to put them up, or if anything that people have questions on, but I'll pause there and say that's where we are with treatment. Still more to come. We'll know more we'll be better we'll know more in a month than we do now, and we'll know more certainly in 6 months than we do next month. So that's where these trials really come, why they're so critical.
Thank you very much, Dr. Gandhi. That's really very helpful. We actually have a few questions around infectivity and risk reduction. And I'm wondering, many of our patients are asking about being outside of their home, going for a walk or visiting the grocery store. Can you speak to these safety concerns and let us know what are the reasonable precautions we can take for things like wearing masks and gloves, disinfecting mail or groceries, or having to remove clothing if you've been outside?
Sure, I'd be happy to. And actually, before I try to address that question, I see something in the chat that I neglected to mention, so maybe I'll just say it here. It's about treatment, and then I'll go right back to the risk prevention question. So the question that was asked is about an investigational drug called remdesivir, which again, you may hear some about in the news. We at Mass General are doing, in fact, we're one of the top enrolling sites in the country for a remdesivir study. It's a drug that inhibits the virus from making copies of itself. It was tried in Ebola some years ago and was not as good as antibodies, but it does work in the test tube against the virus that causes COVID-19. And so there are trials in China, as well as a large National Institutes of Health study here in the United States that are going to test that. And I do think we'll know more, probably, if not this month, certainly next month, about remdesivir. So sorry I didn't explicitly mention that before. So for risk prevention, I do think that the prevention methods that are been promoted are really working. I do think the social distancing, staying at least 6 to 9 feet away from people. I think covering the face when you go out is really a very wise idea, and I would recommend it strongly to cover the face when you go out. I think avoiding crowded areas for sure. I'm going to the grocery store during hours where it's less crowded. In terms of items that come from the outside, say you have food delivered or you get a mail package, what I counsel my patients and what I do myself is I don't try to in any way disinfect or do anything particular to those packages. What I do is after I open the packages, I do I wash my hands for at least 20 seconds to, that will kill the virus. And beyond that, I don't worry about getting delivery food or Amazon packages or whatever it is that we all need to get when we're at home. I just do wash my hands though after handling the packages, but I don't disinfect the objects themselves. And that goes for mail and groceries, and similarly for clothing. No particular concern around clothing worn outside. I don't personally, and I don't recommend my patients when they've gone outside with clothing, unless the clothing is soiled. I don't recommend that you change it when you get home. So, does that answer that question?
That's perfect. Yes, thank you very much. Many of our patients, we discuss with them the possibility of having, say, a visiting nurse come into their home or a home health aide or someone to come in and do a diagnostic study like a blood test or something like that. Many of our patients and families have expressed concern about this. My understanding is any of these agencies are also using personal protective equipment to ensure that their patients are safe. Is there anything else that we can say to reassure our patients?
I think you're right. I think the visiting nurses and home health aides are using appropriate precautions. What I counseled a patient about earlier today, who happens to be a home health aide, is that careful symptom review on his part. So does he have any fevers? Does he have any shortness of breath? Any sore throat? Any symptoms that might suggest an infection? And then I encouraged him, of course, to wear face coverings when he's seeing his clients. So, but I do think I understand the concern. I have patients of my own who have that same concern. But I do think with those proper precautions, the wearing of face masks, as well as symptom checks, fever checks, and symptom checks, that on balance the benefit is there. So.
Thank you. I have two more questions for you, and one is, can you speak to us about those of us who have pets and are concerned about infectivity between species?
It's a good question. I wish I was a veterinarian and knew the definitive answer. My understanding, I can perhaps, if you invite me back, I can give a more detailed answer in the future. My understanding is for pets like dogs, there's not been a particular concern about infection. I think there is some data, and this is evolving. So anything I say now might change next week or even tomorrow. But I think there are some data about cats having the ability to have COVID, but transmission from cats to humans, or from, I think someone asked about a lion at one point. I think about felines to humans, I don't know of any cases of that. So I don't, what I also tell my patients, and I would say to all of us, is there's real benefits to, in this time of social isolation, not to be distant from family and pets and support systems is really key. And I think the benefits of our social contacts done virtually, as well as our pets, really outweigh the risks. We need to stay mentally strong. Humans we have to physically distance, but we're not meant to be, apart from other people in our support systems.
Thank you so much. The last question is, and this is sort of in the realm of how things are progressing, both at the local level and the national level. We have several patients in different parts of the country who are asking about travel tips and when they should start thinking about planning to return to Massachusetts. I don't know. I know you can't give us an answer, but can you advise us on how to think about us making travel plans?
Yeah, that's a great question. Here, even though I'm an infectious disease expert, or that's my specialty, really here and we all should take our lead from the public health authorities. They work at a level that even goes beyond the individual infectious disease physician, because they have access to data that goes beyond any particular hospital or any particular region. And so, I don't know really how to answer that question, other than this is a place where the experts really are where we look to. And that's true in the hospital. If someone has a condition that, like an infection or COVID-19, how should they be managed? But here I would defer to public health authorities. And we'll see. I mean, they're working overtime, as we all are. So there is a question, and I could take this if you'd like, about oximetry at home.
That'd be great. Yeah, sure.
Yeah, this was a topic of a New York Times editorial by a physician working at Bellevue Hospital in New York City. Oximeters are devices that are used in the hospital, as many of you may know, to measure how much oxygen is in the bloodstream. They can be, pinned onto not pinned, but put onto the finger with a little clothing pin type of device, and it measures the oxygen without. It's not invasive. There's no needle. It is something that I think, in my own experience, the symptoms of shortness of breath are ones that are really the hallmark, or the thing that would alert. I would want to know as a physician that my patient is experiencing. As to whether they can be silent hypoxia or silent low oxygen, that was the point raised by that New York Times article. I think we just don't know enough to say that all people should be, stocking up on oximeters. I don't think we're there yet. If someone has an oximeter for some other reason, maybe they have chronic obstructive pulmonary disease or asthma, some lung condition, then I think in the setting of symptoms, if it does dip below 94%, which is usually considered a normal, 94% and above is considered normal. And if that's unusual for the person, then I think that would warrant a call to the physician. I wouldn't say that in some parts of the country, they are some people who are at particularly high risk, if they have access to oximeter, are using that. We're not quite there yet in my own practice or in Massachusetts. I think it's an evolving target. Symptoms, fever, and shortness of breath, and then oximetry, may have a role, but I think it's still being defined.
So what I'm hearing is they have to be sort of medical high grade, good quality,
yes,
and
yes.
should not be interpreted by yourself, but in conversation with your provider.
Yeah, that's the right answer. Basically, that's the type of thing, depending on the particulars of anyone's situation. Maybe that's something to talk to your physician about. Should an oximeter be available, and how to interpret it, rather than make a blanket endorsement or a blanket, rebuttal. So.
Excellent. Well, thank you.
Sure.
Thank you so much for your time. We realize that you are in high demand, and we really very much appreciate your assistance, and stay on as long as you can, but we understand if you have to leave.
So I'm going to say that today, because of a prior commitment, I will step off, but I will be happy to come back in the future. And I know this is a time of great flux. That's true for all of us. And so, I'm happy to come back and whenever you'll have me. So.
Excellent. Thank you very much.
Okay. Yeah, my pleasure.
Thanks, Dr. Gandhi. And next, I'd like to introduce Dr. Sarah Turbet. She's the Assistant Director of the Microbiology Laboratory here, and also a member of the Infectious Disease Division. Dr. Turbet, are you there?
I am.
Okay.
Can you hear me?
I can hear you. There you are, and I can see you. Yay. Okay, excellent.
Oh, good. Okay, you can see me. Does that mean everyone else can see me?
Yes, we all can. Yes.
Okay, perfect. Okay, all right. So tough act to follow, because Raj is fantastic. But I believe I'm here mainly to discuss kind of testing for COVID-19, what is currently available, what is potentially on the horizon. Brief overview, we in general have 2 tests right now looking for COVID-19. The one that is most widely available right now, and if you've been tested for COVID-19, the one you probably had is what we call a PCR-based test, where it's looking for viral particles most likely in the nose. However, other specimen types are also possible. And this is really what we think of as the kind of gold standard for the diagnosis of acute infection with COVID-19. In that if you have symptoms, we perform this test, and we feel like we're quite confident that we will pick it up if it's present. The other type of test that is kind of now coming on scene and that there's been a lot of discussion about is what we call serology, which is essentially looking for antibodies to COVID-19 in a person who has been infected with COVID-19. And so antibodies are the body's way to try and fight off an infection when someone has been infected with something. We use that as a way to kind of determine if someone has in fact had infection. And this is a common practice. A lot of you have probably had antibody testing for all sorts of other things. So for example, measles, when we have outbreaks for that, we often sometimes have patients get antibody testing because it helps us to determine if they've been infected in the past or how potentially immune they are to a new infection with that same organism. I will say that serology is really not used for an acute diagnosis, meaning if you're presenting with symptoms, really the best test is still a PCR looking for viral particles in the nose. Serology testing is often more used to look for past infection for either epidemiologic purposes and in some instances to look for immunity. I will say that it's unclear at this time if having had COVID-19 and then having an antibody response to COVID-19 actually imparts immunity, meaning if you have antibodies to this, does this mean that you actually would not get COVID again? We don't know that yet, but this is an area of ongoing research because certainly that's important for us to understand. There are some serology tests available at this point. There are many on the market, I would say, but only 4 of them have actually received approval from the Food and Drug Administration for use in kind of an emergent setting. And so it's important to really understand the characteristics of that serologic test. How good is it at actually finding antibodies, and how specific are these antibodies to COVID-19 as compared to other viruses that are very similar to COVID-19? And so at MGH, we are actively looking at all of these assays. They are being used in a very limited capacity, predominantly in hospitalized patients currently. And we are working to really best understand how best to use this for people because there are still so many unknown questions about antibodies, how they work, and how best to use that information in the COVID era.
Excellent. Thank you so much. So I'm monitoring the chat bar as well.
Oh, perfect. Okay.
I know that we've had a lot of our folks are asking about, well, I think I want a test, and we're often fielding calls from our patients, and going through a triage. And I'm wondering if maybe we can spend a little time about that and why we're not testing everyone.
Yeah. I think in a perfect world, when we had, 100% availability of tests, I think we would certainly be offering tests to, all people who have symptoms that could be suggestive of COVID, and even patients who do not necessarily have symptoms but might have risk factors for COVID. So, living in an area where we're seeing a high prevalence or things like that. And unfortunately, the truth is that testing, although much better than it was 2 weeks ago, 4 weeks ago, 6 weeks ago, is still limited. And so as a result of that, we are currently still actively triaging our testing to really focus on patients that we think either have the highest, probability of having infection or that we think would benefit most from having this diagnosis. And so currently, MGH has a full set of guidelines, and I will say these are being updated regularly in real time, all of the time. We are constantly thinking about this, but it does very clearly outline who can get tested. And it includes, but is not limited to, just because I cannot actually list all of the different people, but it's some asymptomatic patients. And so that would include people who might be going for urgent surgeries where we really need to understand their COVID status before going into the OR. It might also include, women who are going to give labor, and therefore there'll be a newborn, and obviously concern for exposure to the newborn. And then symptomatic patients would be, predominantly patients who have symptoms suggestive of COVID-19, fever, cough, sore throat, shortness of breath, and then who meet specific what we call high-risk criteria. So anyone, 70 or older, or if they have chronic lung problems, chronic heart problems, those would be people that we would really try to prioritize for testing. And so I think the big takeaway here is that, if you're having symptoms that seem like they could be related to COVID-19, to please contact your doctor because they can work with you to determine whether or not you need testing and also how to then get that testing in a timely manner.
Great. Thank you. The issue of how long I'm contagious and can I get COVID more than once? Because we have patients who are they have it, but then they're testing negative, but they're wondering, what does this mean down the line for me or for my family?
Yeah, that's a great question. And I will say this is something we are still learning a lot about, areas of ongoing research. Right now, we don't really know how long someone is contagious with COVID-19. We don't. We are using the best information we have to make determinations. And I will say it's not based just on a lab test. So it's not based just on testing negative. It's also based on clinical criteria as well. So where are what are your symptoms? How long have you had them? How long have they gone away? And so it's really a collection of information that is used to ultimately determine whether or not we feel you are still, contagious in the kind of quote unquote from COVID-19. And then the second question was, could I get reinfected? Another thing that we really just don't know at this point. A lot of that hinges on the antibody response that I was mentioning earlier. In that if you have it and you make antibodies, are those actually protective? And we just don't know that right now. And so that is still something that we are looking into and that the research community at large is looking into.
It's very challenging for all of us. We're learning this disease at the same time that it's happening.
Yeah.
We had 100 years of research on influenza that we could inform, but we're all seeing this unfold at the same time. So having to be comfortable with the uncertainty in the preliminary months of this disease is very challenging, not only for our patients, but also for us as healthcare professionals.
Dr. Russell, we have one other question in the chat room that Dr. Turbot could maybe address, and that is, if I understand it correctly, can you say a little bit about where we are with in-home testing?
Great question.
In-home testing. So great question. At this point in time, all testing at MGH is still being done at dedicated centers for testing. So be it a respiratory care clinic or even, there are certain DriveThru clinics, for example, all of the testing is still there. There are, at least to my knowledge, is not an FDA approved in-home test. And so I think for the moment, testing is still going to be at clinics or DriveThru clinics, things like that.
Great. Excellent. Dr. Turbot, thank you so much for taking the time out. As we said to Dr. Gandhi, I know your time is precious and you're in high demand. Feel free to stay on as long as you can, but we understand if you have to leave. Thank you.
Oh, thank you for having me. I'm going to pop off. I have a similar commitment as Raj, so, but I'm happy to come back and answer any questions at any point in time.
Appreciate it. Thank you so much.
Thank you.
Next, I'd like to introduce Dr. Sharon Levine, Section Chief of Geriatrics here at Mass General Hospital. She's going to speak a little bit about what we're doing here in the senior health clinic.
Well, hi everybody, and I want to welcome you all to the town hall and to thank you for joining us. So as you've learned from Drs. Gandhi and Turbot today, there's so much we're learning about COVID-19 and flying the plane and building it at the same time. But it's great to be here at Mass General because so much evaluation and treatment is going on and so much research is moving the needle in the knowledge of this new virus. But we also know that for you and also for us, and actually listening to Drs. Gandhi and Turbot, there's still a lot of uncertainty. There's so much uncertainty. When will I see my family and friends again? Can I see my family? When will I see my family in the assisted living or in a nursing facility? When will my personal caregiver be able to come back? How is my family? When can I get to my adult day health program? When will I feel safe? And when was life going to be normal again? That's really how we all feel. But I want to say that there are some things that are certain. Spring is here. Daffodils, tulips are blooming. Magnolias and cherry trees are blossoming. Lots of robins are singing. We know that coronavirus is spread by droplets and contact. And this is the most important thing, senior health is open for business as we have been through the entire pandemic. All of us, from our administrative staff, medical assistants, the front desk, our patient care coordinators, our docs and our nurses are working every day, either remotely or as I am today from senior health. We're seeing patients all day, every day, most of you virtually through telehealth or a phone call, as you're doing with many of your other providers here. And every day I try and think of something that has changed, that is a great innovation that we can keep when all of this is over. And being able to reach out to some of you virtually, who, especially those who have a hard time coming in, will likely stay with us in some form or another going forward. We want to know what matters to you. We want to know what's important to you. We're here to answer your questions about your health and the health of your loved ones. And we'll be honest with you about what we know and we don't know, just as Dr. Gandhi and Dr. Turbot were talking about. We know what we know, and we're learning what we don't know, probably more than what we know. Two of our nurses, Andrea Kirkle and Haley Shanker-Redstone, are going to talk to you now about what the experience consists here at Senior Health and how it works to do virtual visits. And it will be wonderful to listen to them talk to you about that. So stay safe, keep social distance, wash your hands, and cover your nose, mouth, and chin with a mask, the whole thing. Take a walk, even a short one, and admire our blooming spring. It's pretty nice out there when it's not raining, and it's so good for you in so many ways, for your spirits, for your brain, for your heart and your lungs, your bones and your muscles. We'll see you soon, one way or another, whether it's virtual or in person, but take care. And I'll now pass this on to Andrea and Haley.
Thank you, Dr. Levine. Good afternoon, everyone. My name's Haley, and I'm going to take a few minutes to focus on some changes Senior Health has made during these challenging times. If you're a patient of another practice, I do encourage you to reach out to them to find out what changes have been made if they have not done so already. You may have noticed over the last month that a Senior Health staff member has reached out to you, informing you, like Dr. Levine said, that we continue to be available and we're still here to serve your healthcare needs. We'll continue to reach out proactively to schedule telemedicine appointments, either with your PCP or with one of the nurse practitioners in our office. We do have a multidisciplinary team here, so there's the PCPs, the nurse practitioners, as well as a triage nurse who's available to answer any of your questions, and a social worker who can help assist if you have any problem-solving needs, if you need some help finding additional services in your home or in the area, we can try to help you with that. Even though we currently are in the COVID pandemic, it's important to acknowledge that your other medical conditions do still need to be addressed or followed up on. We're able to perform telemedicine visits, like Dr. Levine mentioned, both for any acute complaint you might be having or for your chronic medical conditions. If you do not already have a follow-up scheduled with us, I would encourage you to reach out to us and schedule a follow-up appointment so we can make sure we're addressing your needs appropriately. Your healthcare is very important to us, so we want to make sure nothing slips through the cracks during this time. One of the priorities for us at Senior Health is to keep our patients safe and healthy. The key to success is managing your medical conditions proactively as opposed to waiting for them to worsen. So I do really encourage you to call us. That's what we're here for. And if you're not a patient of Senior Health, please do call your primary care provider and discuss your concerns with them. Like Dr. Levine mentioned, I want to remind you that we are always here for you. She said we're open for business, and it's true, we are open for business. So if you do have any questions about your medical needs, do not hesitate to reach out to us. And if you're not a patient here, again, please reach out to your primary care practice, and we will try our best to help address them. I am now going to pass it over to Andrea, who will be discussing our telemedicine visits in a little bit more detail. Thank you.
Hi everyone, my name's Andrea. I'm sorry this is a little Senior Health specific, but just to give everyone a rundown of what we're doing for our telehealth visits for right now. In an effort to reduce the risk of exposure, we're attempting to complete visits virtually when appropriate. Patients that do not have access to video technology will be seen via telephone calls, but patients that have access to the correct technology will be able to be seen in a video visit. Video visits are the preferred method because they not only allow the provider to complete a visual exam, but they also normalize the experience for you and the provider. To complete virtual visits, you can use smartphones, smart pads, computers, or laptops. You'll need to have internet access or a data plan on your phone. You can schedule visits by calling into the office and requesting an appointment. The front desk will be asking if you have the technology to complete a visit via video, and if so, you'll be asked for your email address, through which a link will be sent to you. If email is not a viable option, you can opt to receive a text message with the link instead. 15 minutes before the time of your scheduled visit, please click on the link and it will launch you into a virtual waiting room where your provider will meet you. We're making every effort to remain on schedule, but if we're running a little bit late, you may receive a message through the virtual platform letting you know. These visits will be billed to your insurance like usual office visits. We will do our best to provide updates to you if the process changes with time. We really want to reassure you that we at Senior Health are still here to support you and will continue to manage all your medical needs during this time. Now, if you're not a patient of Senior Health, I really encourage you to reach out to your practices because I'm sure they're making similar adjustments as well. Thank you. And I'm going to pass it back to Matt.
Great. Thank you, Andrea and Haley, for that. It's one of the questions that was in the chat is there a particular video tool that older patients have found easy to use for telehealth if they do not have a smartphone? And just to restate, this is something, if you have a webcam on your desktop and you're able to log on to the internet, this would be the way that this could be sent to you. Do you guys have any comments on that? Okay. All right. Now I'd like to just take a moment to introduce Susan Rowlett, who is the director of our Dementia Care Collaborative, to say a few words related to what we're all going through and also the fact that our loved ones who have dementia still present care challenges, and we want to make sure that they're cared for in the best way we can.
Thank you, Dr. Russell. Again, my name is Susan Rowlett, and I'm the program director for our Dementia Care Collaborative at MGH, and we are part of the division of palliative care and geriatric medicine. And I just want to thank all my colleagues at Senior Health for all the work that you're doing. The Dementia Care Collaborative is here to support you and all of your patients and families. I just wanted to say a few words just to let people know in case you do not know about us. During this time, we're also doing a lot online. We're seeing people virtually for individualized counseling sessions about living with dementia, especially when we're all cooped up at home, everybody's stir crazy. How do you keep busy, find moments of joy, and manage all of the challenges that you are faced when you are at home with this COVID pandemic, but also living with someone or maybe experiencing memory challenges yourself. So we're offering a lot of online forums as well, just like this town hall. For instance, one of the topics we have coming up on April 30th is having difficult conversations about illness and making plans in case something were to change for the caregiver or if someone were to be ill in the family. On April 30th, we have two of our experts from our home-based palliative care program and our Continuum project who are gonna talk to us specifically about dementia in this context. We have other forums about activities to do throughout the day. We're gonna have some education programs about communication, managing challenging symptoms, and safety. We have support groups that we have moved online, and we have added groups. We also have a wonderful music and movement program that's being offered twice a week online, just like this. So we all get together. Our program coordinator, Nori, who is wonderful and very funny, leads us in a very joyful music and movement program we call Ageless Grace. And also the individualized counseling is available for patients at MGH and your families. So If you're not on our distribution list to get notifications, I'm going to give you the email address because it's long, but it makes sense, and we'll also provide it for you in the chat area, and it'll be on the geriatric website as well, senior health or geriatric medicine website. So the email address to let us know if you want to know about our programs is Dementia Care Collaborative, the whole word, Dementia Care Collaborative at mgh.harvard.edu, or call 617-724-4046. I also give a shout out to Emily Sterling Graves, who's the social worker in senior health. She can also counsel you and provide all services and refer you to our program. So Dr. Russell, thank you for giving me the opportunity to talk about our work. I appreciate it.
Thank you so much, Susan. I appreciate it. We have a little time now for an additional review of some questions that may not have been answered during the course of the session so far today, or that are specific to our patients in senior health. So I'd like to provide some important updates and recommendations from our hospital colleagues that you may all find very relevant. In our last town hall, many people were concerned about the visitation policy during the time of COVID in the hospital. I'm happy to report that the visitor policy has changed as it relates to patients with cognitive impairment due to dementia or delirium. These patients can have one visitor with them in the emergency room and during their hospital stay. This is to facilitate communication, help with behavioral symptoms, and prevent delirium. Delirium is an acute state of confusion that is typically due to a medical condition and is characterized by inattention, disordered thinking, and fluctuations in level of alertness. This can be very frightening for patients and families, and we know that the presence of a family member can often help to reduce that risk. Secondly, our emergency room partners have asked us to make sure that we remind all of our patients with sensory impairment, i.e., visual or hearing difficulties, who may require a trip to the emergency room or subsequent hospitalization, to please ensure that they bring their hearing aids and glasses. Sensory impairment is challenging for providing care, especially in patients with cognitive impairment, and we want to ensure that they are able to hear our thoughts and recommendations around medical decision-making. Finally, many of you have asked about access to senior health. We are committed to reducing our patients' risk for contracting COVID. We are currently almost exclusively conducting visits using virtual platforms. If for some reason you are asked to come to the clinic, you will likely be the only person in the waiting room. We would ask you to continue to observe social distancing, wear a mask, and practice hand hygiene. Please also know that the elevators and common spaces are being cleaned regularly. Next, you've asked about some emergency preparedness during COVID. As I'm sure you all know, Mass General is partnering with state and local commissions and several academic centers in Boston and throughout the world in order to understand more about this disease. At present, we remain able to care for the current volume of patients and have access to ventilatory support if needed. If you require hospitalization for any problem, COVID or otherwise, and wish to come to Mass General, please notify your responding paramedics in the event of an emergency. Emergency medical services typically attempt to bring a patient to his or her preferred hospital. If the patient is determined to be clinically worrisome in terms of symptoms and or vital signs, however, the paramedics may expedite your care to a closer hospital for stabilization. What we know about this illness so far is that decline can be sudden, and our recommendation is to defer to paramedic recommendations if clinical stability is in doubt. We talked a lot already about our rigorous screening process for patients who may be experiencing COVID symptoms. If you're not sure and have a question, please feel free to reach out to us at Senior Health or your primary care provider if you belong to another practice. We talked also about how do I monitor myself at home. Many people have, either through fitness apps, or prior healthcare episodes, they may have access to oxygen monitoring devices. These may not always be medical grade, and as Dr. Gandhi said, we are not recommending that folks go out and buy a pulse oximeter at this point. However, what we do know from quality medical instrumentation is that a downward trend in oxygen performance, i.e. oxygen percentage, that can be a harbinger, as this clinical sign often precedes overt symptoms such as fast breathing or the subjective sensation of shortness of breath. When we really should be worrying about ourselves is if we have difficulty breathing, persistent pain or pressure in our chest, if our family members are having new confusion or unable to be roused, and if there's any bluish discoloration in the face or lips. Several patients have asked for updates on COVID data in Massachusetts, and as of yesterday, there are 42,944 confirmed cases of COVID in Massachusetts. Of these, 3,977 are hospitalized. The average age of hospitalized patients is 68. Hospitalization rates and mortality risk are highest for patients over 80. Boston continues to have ICU bed availability. At Mass General, we currently have 477 patients hospitalized for COVID, with 177 of them occupying the ICU. We are seeing patients on a ventilator for a long period of time. We are seeing patients come off that ventilator. We are seeing people leave the hospital. In terms of the percentages, that data remains, I feel like this is the word of the day, still uncertain because we do not have enough information to provide a predictive model. Given the fact that we have such variable data, and the fact that many intensive care specialists are observing prolonged patient time on a ventilator with a relatively high risk of mortality, we at Senior Health have attempted to engage our patients in discussions about preferences around intubation or resuscitation. We worry that many of our frailest patients would not fare well if they required mechanical ventilation due to COVID. We also know that many of our patients are not frail and remain quite vigorous. Please take time to consider this, and whatever you decide, please make your care preferences known to your healthcare proxy, family members, and providers. We don't know where we are yet in terms of our peak and our spike and where we are on the curve. News is cautiously optimistic at present, but we will continue to provide these venues to answer any questions you may have with the most up-to-date information that we can provide. With that, any other questions?
Yes, there are some other questions.
Great.
A very important one that came in is, how can someone know if an advance directive has been made part of their health record?
Great question. So typically we will have access to that in our provider-facing part of the healthcare system, but there is also a section, I believe, in the patient gateway where you can do that. If you are not sure, you can always send a message to your provider's practice through the patient gateway, and we will be able to check to see if we have ever had this conversation. What's very important to know about this is that for many of us, we've been in the hospital before, and we may have had this conversation 5 or 10 years ago with someone, and it might be on the record that we wanted, for example, I don't want to be resuscitated, or I do want intubation. But that may no longer be relevant in your health status now. So what I would definitely do at the very least is check to make sure that, number one, there is an advanced care directive, i.e. talking about your preferences, and two, that it is up to date and in line with your current wishes around your health care.
Another question that came in is, what happens if you have COVID-19 and you're an organ donor? Can you say a little bit about what are the policies around organ donation?
That is probably something I would defer to the infectious disease specialists, because if you are about to undergo organ transplant, you are a high risk and would be treated. Similarly, if you are to donate, I would imagine they would screen you for COVID at that time. Having the antibodies, it would probably be less concerning than if you were still shedding virus.
Okay,
That's my generalist doctor answer, but I'm pretty sure it's consistent with infectious disease.
Okay, thank you. Another question that came in is, if you think you need to be tested, should your first choice be a drive-through COVID test facility, a respiratory clinic, or some other facility?
So it's actually, it seems that patients can talk with, once we, in our practice, do an initial triage of our patients, we make a referral to the testing department, basically. They will then reach out to the patient and decide whether it makes sense for the patient to come into the respiratory illness clinic or a drive-through. So that's not something that we would make as the senior health folks, but rather as part of the coordinated effort of the Partners Health System around testing.
Okay, thank you. Another question that came in that I think is probably a question we all have is, there's been a lot of discussion about this week being the week that we would expect things to peak in Massachusetts. Mm-hmm. And the question is, when is the spike over? And when, does anyone have any idea about when things may open up?
Yeah, we asked Dr. Gandhi this, and it is actually still very, very unclear. We've seen that the peak in some cities has actually lasted longer than anticipated, and because we are trying to flatten it, the duration to opening up again will likely be longer. So I'm looking at the Mass Department of Health, Public Health, and also listening to Dr. Fauci to hear that news as well. I think we all want to know that. We're also very concerned about what happens if neighboring states or other parts of our country open up and relax some of the social distancing, what impact that will have on us, and what will be my personal choice around continuing to be socially isolated versus going out into public venues again. So I think it's a stay tuned answer is the short and very unsatisfying, admittedly so. Short answer.
Yes. There are a few questions again that focused on issues around when you can touch surfaces, mm-hmm. That Dr. Gandhi touched on, but maybe just to reiterate those, particularly about cardboard and packages and things like that.
Yeah, and I think that the general gist is your hand washing and your own hygiene is going to be far more impactful on your health status than what is transmitted on a box or a letter. That really, it is about, opening it, washing your hands, and throwing it out so that it's not staying around. I think I also saw some questions around additional antiseptic using copper and all of these things. Yeah. I would just be very careful, and this is more from a beware of snake oil salesman. Yes. And I would say what is effective and what is proven effective is not clear. And if these items are high cost and you may be financially constrained, I would stick with a mask and hand hygiene and social distancing before I would buy any other things that really might not yet be evidence-based.
Thank you. We've got just a couple of minutes left, and I just want to make sure to let people know, if you have any other questions about virtual visits, how to get your care through the telehealth programs, now's your chance. If you have anything else you'd like to ask Haley or Andrea. And I will also share a quote with you that someone shared with me that I think speaks to a lot of the frustration and the concern that we have about the uncertainty that we're all learning to live with every day. It's an Arabic proverb those who pretend to know the future lie, even if they accidentally speak the truth. So I'm going to try to keep that in mind as we're all trying to understand what are the things that we really need to pay attention to. And I think we've gone over many of them today that are very practical and very helpful. So Dr. Russell and Dr. Levine, any last comments?
I just want to say that once again, it's wonderful to be able to reach out to you all and to see your faces in your homes. I love doing this because as a geriatrician, so much of what we do is, well, what's going on at home? Well, now we can see what's going on at home and we can help that much better. And I think that this is, as Dr. Levine said, this is something that we're actually very excited about. Rather than having people schlep in here through Boston traffic and getting stuck on Cambridge Street, could we just do a checkup in their home and actually see why isn't our plan working, or get a better sense of things. So I want to thank you for letting us into your homes, and thank you for your continued trust in us. And I wish you lots of good health. And as Saint Teresa of Avila says, "Nada te turbe, nada te espante, todo se pasa." Don't let anything bother you. Don't let anything frighten you. Everything is passing.
Thank you very much. We enjoyed it.